This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This is Sarah, and I just want to take a moment to speak to you about this week's sponsor, Favor. Favor Inc. is a statewide family-led nonprofit 501c3 organization that is committed to empowering families as advocates and partners in improving educational and health outcomes for our children. Favor is the Connecticut state organization of the Federation of Families for Children's Mental Health. Favor offers a single place for families with children who have medical, mental, emotional, and behavioral health challenges to find information, assistance, and training. To find out more about Favor, please go to favor-ct.org. We are grateful for our opportunity to work with Favor as a sponsor, and now on to the rest of the episode.
This episode is brought to you by CogniView. CogniView provides cognitive assessment tools to a broad range of healthcare providers for the early detection of cognitive impairment. Early detection allows patients to address modifiable risk factors sooner, potentially changing the course of cognitive decline. It also allows healthcare providers to develop a plan with the patient and caregiver so the patient can live their best life during their journey. For more information, go to www.cognivue.com. That's www.cognivue.com.
Hello, everyone, and welcome to Caregiver Chronicles. My name is Sarah, and today I have Dr. Monique Nugent with me. She is the author of the book Prescription for Admission. She is a practicing hospitalist and physician leader in the Boston area. Hello, Dr. Monique. How are you today?
I'm good. Thank you so much for having me.
Thank you so much for being here. Can you please further introduce yourself to my audience?
Yeah. So, like she said, my name is Dr. Nugent, and for this conversation, you can call me Monique. I'm a hospitalist, and the first time people have that introduction, they usually go, "What is that?" Right? And so I'm an internist, and I practice exclusively in the hospital. I don't see patients in an outside clinic. So that means that if you come to the hospital and you need to be admitted, but you don't need the ICU, you're likely to be cared for a hospitalist, someone like myself. So I've really built my career around hospitals and hospital care, post-acute care, transitions of care. And it's a place that I really feel like I jokingly say everybody goes to two places in America, the DMV and the hospital, at least once in their life, right? And so it's a place where kind of everything comes together, and I get to meet people of all walks of life. I get to help people at all stages of their life, and it's a career that I've thoroughly enjoyed. And so it was like for me, a natural step in my work to advocate for patients in hospitals to write to patients. And that's really what this book is. It's a book for patients, to patients about the hospital and what to expect, how to navigate it, how to prepare yourself for, like I said, all the things that will happen, the transitions of care, and what goes on after you're hospitalized. Because, leaving the hospital is often not the end of somebody's story when it comes to an illness or injury. So that's who I am, and I'm really excited to talk to you.
Thank you so much. And I think it's interesting that the term hospitalist is not a term. I think a lot of people are familiar with it. I know you defined it a little bit, but can you just give us a more clear definition for my audience?
Yeah. So hospital medicine is the specialty of the care of acutely hospitalized patients, meaning caring for patients who need to be in a hospital setting for an acute and active illness, injury, whatever it is, process. The specialty of hospital medicine, and therefore the people who practice that specialty, which is hospitalists, really kind of came about in the early mid 90s. So traditionally, the way that patients in the hospital were cared for was that their doctors, their local primary care doctor, their specialists would be notified and say, hey, your patient was admitted to the hospital via the emergency department. Or they would say to the patient, hey, I would like to admit you to the hospital, and they would send them over. And the doctors would kind of go between their office and the hospital. And so it was kind of a split to me practice. And that's great in certain ways in that people were seeing their primary care doctor, the people who they have built long-lasting relationships with and who know them over years. But it's also not great because this person's attention is split and their availability is split. Things happen quickly in a hospital. The changes that we need to make for our patients' care, meeting with family members, the things nurses need to care for patients, really nowadays requires somebody to be available almost instantaneously. And really, that's what hospital medicine was. It was a group of young physicians who said to the clinicians in the office, hey, if I make a contract with you to say I will care for your patients when they get hospitalized, I will do all that stuff. You stay in the office, and we have this mutually beneficial agreement. And that's how the specialty came about. So it's one of the younger fields of medicine in that we don't have like boards that are ultra specialized, like a cardiologist, right? A cardiologist takes another set of boards. We do have fellowships. We have academic fellowships. I myself did a non-clinical fellowship based around healthcare policy and management, right? But it's also a really helpful specialty for hospitals and hospitalized patients because you get someone who's well versed in the things that are necessary for your safety to create a timely care plan, somebody who is there all the time. Another term you probably have heard less of is the term nocturnist, right? And that's a hospitalist who practices only at night. And so when I leave, I turn over my care to the nocturnist, and they're in the hospital responding to emergencies through the night, helping nurses take care of patients through the night. These are really active processes. And then admitting patients so that we don't get this backup of patients not being seen by doctors at all hours. So like I said, you're right. A lot of people don't know the term, both when I introduce myself to patients in the hospital and when I introduce myself to my mom's friends when they're like, what do you do? And my mom goes, she's a hospitalist. And they're all like, a what? It is a bit of a newer term. And so I'm someone who practices hospital medicine, but it's a form of practice that a lot of specialties have seen to be beneficial. So in the world of obstetrics and gynecology, there's a specialist called a laborist. And that is a person who works specifically in the hospital with laboring patients. And again, if you can think about it, labor can kind of happen at any time. And this idea that an obstetrician was running back and forth in these older models of care. But now you have somebody and a system that is there in the hospital for anything that's happening. Surgeons have also taken up this model. They call themselves acute care surgeons. So there's surgeons who are there for whatever comes in through the emergency department and whatever's happening on the floors in the hospital that we need. Your intensivists, people who practice just in the ICU, they're kind of the like OG hospitalists, right? Because you don't have like an outpatient ICU. So they were always like very hospital based, right? But sometimes they do split their time between seeing pulmonary patients in the clinic. But again, there are some who just see patients in the hospital and work in the critical care. Pediatrics has also taken up this model of care. There are pediatric hospitalists. And so we find that this is a model of employment and care that really does benefit patients, the system, and the clinicians.
Yeah. And I think that that's actually a really good thing because you have communication with the doctor, but you're not like you said, you're not split between working in a doctor's office and then going into a hospital to visit patients. And the doctor isn't split between those two things. So the doctor, he or she, they can be present for the patients who need, office visits while you're there in the hospital. And there's, obviously like clear communication. Is it the same doctor that you work with or the same group of doctors that you work with as the hospitalist? Is it just whoever gets admitted and then you seek out whoever their primary physician is?
So there is a law in this country called EMTALA, the Emergency Medical Treatment and Labor Act, which requires emergency departments to take anything and everything that walks off of the street to assess and stabilize patients, which means that hospitals have become essentially um, a- able to care for everything, stabilize things, send them to places if they can't care for them that can deliver that care. And so I think it's the nature of US healthcare that people are not wedded to one hospital, one clinician in their primary care group, one specialist, and also like insurers change as people's employment changes. So right now, it's not as seamless as people would think that my primary care doctor is associated with this hospital. It depends on contracts and ACOs and catchment areas and ambulance catchment areas and things like that. But we do and we should have information on who someone's primary care doctor is built into the emergency medical, I'm sorry, into the electronic medical record. And we can ask, we definitely ask. And we do see a number of patients who don't have primary care physicians as well.
Thank you so much for that. And that's just something I was wondering was like, do you have to have a specific doctor to have a specific hospitalist or, and it sounds
Yeah.
like
No,
that's
I think that's a great question because there are so many models of healthcare in this country. So like out west, the Kaiser Permanente group, they really manage their patients. Kaiser Permanente patients see Kaiser Permanente physicians and go to Kaiser Permanente hospitals. And if one of their patients tends to be at a hospital or ends up at a hospital that's not within their system, they will go and get them, right? That's really like how cloistered that healthcare system is versus patients who may be uninsured or on state insurance and they get their care through like county or city hospitals, which may not or be associated with primary care doctors that are private. And they may have more like broken up type of care versus patients who need ultra specialized care and who are seeing specialists within one system because their local community hospital and their local primary care doctor cannot deliver those highly specialized needs that they have. So it really does just kind of matter where somebody's is, kind of where they showed up. But I think what you really bring up is a really good point about building a history within a hospital because if you tend to go to the same hospital, they will have a lot of your records, right? And they will have evidence from previous hospitalizations, different tests, labs, op notes from surgeries. All of that builds up your story so that if you need to be hospitalized again, the system is a little bit more primed to support you. I can go back through your notes, your discharge summaries, and see. If my health, excuse me, if my hospital is associated with your primary care doctor, that's even a bigger boon because in theory, I should be able to get directly into their medical records. And so that helps that I can look at people's primary care notes, cardiologist notes, all of that, because that communication that you're asking about, that's the thing that's necessary to assure safety and a good care plan is made. And a lot of the times communication now isn't just a phone call. We depend on records and the story that is told in those records.
yeah. You know what? Absolutely. We had a situation with our son where he had been in the hospital a month prior to a seizure for vomiting. He was vomiting and flipping over on his back
Mhm.
and it looked like you could see it go back in. So we needed to make sure he wasn't aspirating. He's nonverbal, can't say anything. I called rescue. I called his doctor first. They're like, you need to call rescue. I called rescue. Rescue girls watched this happen like
Mm.
3 times and they were like, we gotta go. We gotta get this kid out of here. Like we gotta make sure nothing's getting stuck. And his baseline is very active young man. And a few weeks later, he had a massive seizure. And when he was brought in the hospital, and he has a Noah's bed, and he had the seizure in his bed. And so it's like designed for seizures, but it's also designed for kids who do not sleep at night, that can be zipped up in their bed safely so he can play safely in his bed. And I can kind of nod in and out a little bit. When the rescue got here the second time and they saw the bed, they're like, well, does he have a lot of seizures? And I'm like, no. And one of the girls, thank God it's a small town, she was like, I was here a few weeks ago with this same child. She's like, and he was all over the place. She's like, he does not stay still. And they're like, okay, let's go. Like they swooped him up and were like, let's go. And even when we got to the hospital, we had the same nurse for the seizure that we had for the vomiting, and it was a relief. She recognized me and my son right away, and she was like, it's okay. And it was a relief because when I was explaining to them that his baseline was Tasmanian devil, because I don't know how else to describe my son, the nurse was like, yeah, no, she's like, even when this kid is sick, he doesn't stop. She's like, I've seen him bouncing off the walls, throwing up in diarrhea, and she's like, he doesn't stop moving. So the fact that he was being still was terrifying. We did have to have him because again and again, we're talking about the situation where the hospital, our local hospital, the closest one, was not a pediatric hospital. We did have to have him airlifted and transported to another hospital that was outside of our insurance network. It was the closest one. It was in Rhode Island. It was outside of our insurance network, and it was also outside of the state and in the hospital network that we normally use. However, they did a great job of giving me, I also asked for the copy of all the notes. I'm like, I want a copy of everything that happened here so I can make sure that it gets to his doctor there. I know that a lot of times hospital systems can work together, even if they're outside of the same network and stuff. But I don't know. I think as the advocate for my child, or as an advocate for yourself, if you're the patient, is it wise when you're in a situation and you have to go outside your network or outside your hospital for whatever reason to get a physical copy of those notes to bring to your primary care doctor or your regular hospital?
Yes. So the reason why is that, and I know like giving us such a fast answer is not usually what people expect. But the reason why I'm going to advocate for that is that we do not have a standard medical system, or sorry, a standard medical record system in this country. Even when we moved to electronic medical records, and there was a ton of money put into the infrastructure for that, and something called meaningful use, which is where the federal government encouraged health systems and primary care doctors and other providers to use electronic medical records in a way that helps the patient. Even though we've done all of that, there are so many different vendors who create these type of medical records. Yes, there is Epic, which is a major player and the one that a ton of hospitals use, but there's lots of others. And then there are smaller facilities that maybe like primary care doctors who are one-man shop might not even be able to invest in that because it's quite a financial lift to do all of that. So you have all these different hospitals that are not wedded to one system. They use different vendors. And in theory, some of the vendors can speak to each other, and some of the systems within the hospitals can speak to each other. But a lot of that also depends on contractual agreements between hospitals and vendors. And so there is no seamless way. If you stay within a system, if you are a VA patient and you stay within the VA system, the VA has their own proprietary medical record that is used within the entire system, and they can access that. But if you are a VA patient who shows up at a community hospital because you're visiting family and you get sick, there's no guarantee that that information is going to go between each other. And then I'm going to make it more complicated. Your pharmacies that you fill your prescriptions may or may not talk to the different hospitals and primary care doctors via electronic medical records. And then they may not speak to each other, right? So it's totally very, very complicated to get that information streamlined. And if you're being transferred from facility to facility, oftentimes the facilities themselves will print off the last like 5 notes or something like that if they know that the other hospital doesn't have access to it. But I work in a hospital that has access to lots of medical records to the other academic institutions in Boston, and we don't always do that. I'll be on the phone with a physician from one of the academic institutions and I can log into their system. But if someone's coming from Rhode Island, though you're relatively close to me, there's no guarantee that I'm going to have that. So you should definitely try to advocate for making sure that that record gets to the next set of people who need to lay eyes on it.
Yeah. I remember when I took my son to the follow-up after and I had all the notes from Hasbro, um, from Hasbro Children's Hospital. I had every single note from there. And I'm like, here are the note. He had the notes from the local hospital in Putnam because he's associated with that facility, but he did not have the Hasbro notes. And when my son had to go to
Mhm.
CCMC because he has state insurance, he had to go to Connecticut Children's. We had to take all the Hasbro information. And while they do talk to each other a little bit, because in flat out the Hasbro doctors were like, listen, we're gonna do everything we can here because we know that we're the closest to where you are. They're like, but when you go back, you're probably gonna have to go to CCMC. We're gonna all the notes are gonna go there. The neurologist at Hasbro knew a neurologist at CCMC. He's like, he's a great one, like, and that's also New England too. And I know not every state is gonna have that
Mhm.
luxury, especially if it's a more spread out state. You're gonna find it less likely that doctors know each other.
Mhm.
But I know New England again is a fairly condensed area, and everybody knows everybody. But it was that those are like things that I have done for my kid to make sure that there was this continuity and understanding of care in his for him, so that way there every doctor is on the same page for every visit. Everybody knows the medications he's on and what day this event happened, and all those things. I make sure that I have all that information even in a binder. I know that you talk in your book about hospital stays in preventing extra hospital stays. Hospital stays are one of those things that they can be expected or they can be completely
Mhm.
unexpected. For the expected hospital stays, what does planning for those look like?
So expected hospital stays tend to be something that you've scheduled, right? So yeah, obstetrics is expected but not scheduled, if that makes sense sometimes, right? But like let's say that you're going in for a scheduled chemo infusion. You're going to be there for several days. The thing that you want to do is make sure that you know what you're expecting. When you sit down with the physician who's going to set up the admission, say, okay, what exactly are we getting into for the next couple of days? And so really try to build your day around the medical interventions that are going on, right? So if you're going in for a hip replacement, know that like, okay, I'm going to be having surgery on X day. I'm going to see physical therapy on XYZ day. And then what are the expectations of when I can get up and move and where I'm going to go, right? So really having that conversation about how long you can expect to be in the hospital. Yes, there are things that can get complicated that may make a hospitalization longer, but you're if you're being admitted, someone should tend to have an understanding of how long they expect you to be in the hospital. For a planned thing, there are times where you show up at the doctor's office and they admit you kind of unplanned, right? And then try and build your days around those interventions that are planned for you. And also let your community know that you're being hospitalized so that people can check in on you, give you phone calls. You can have some form of social interaction. Hospital stays, whether they're planned or unplanned, can be very isolating, right? You're in the hospital, you're stuck in this kind of pattern for the next 4 or 5 days, and everybody else is still doing their thing. People are still going to school and work, birthday parties are still happening. You don't want to go through a hospitalization alone. So reach out to your community and say like, hey guys, I'm going to be hospitalized for a couple days, but like I'm still going to call you, or do me a favor and call me at 2 p.m. like because my chemo will be finished by like 1:30. And I just kind of, it helps me to talk to somebody if I'm feeling a little nauseous. And so getting an idea of what is expected and building those social supports so that you don't feel alone. And bring the things that make you productive in whatever way that means to you. I don't mean like if you're a stock trader, don't bring in like two screens and a phone, right? But like if you journal, bring in your journal. If you knit and crochet, bring those little things that are going to keep you busy, engaged, not feeling totally down in the pits.
Yeah. I think that that's great advice. Especially like you said, like the crocheting, the journaling, the even reading, music, your headphones. You don't know how much I have had a hospital stay once for myself, and I missed my music, and
Yeah, just
you know,
it's being taken out of your element. I spent bed rest, 2 weeks on bed rest, myself, and I watched a whole lot of Frankie and Grace on Netflix. Um, I had friends come and visit me. But one of the things that I enjoyed doing was, believe it or not, bills. I was told my husband, like, just bring all the bills and I'll put everything in a spreadsheet and I'll and it made me feel productive. Um, there are people who are going to be physically sick and in pain, and they may not be able to do all of those things. And I still encourage to find something like music that does bring you some joy, a little bit of distraction to help with that as well.
yeah, absolutely. And when the nurse comes in, take the headphones off, or when the doctor comes in, take the headphones off. Close the book, close the journal. Be attentive and respectful to them. Even when the people come in to clean the room and stuff like that. Um, Always thank them, especially the people that come in and clean the room and stuff like that. I feel like they don't get thanked enough for what they do.
Environmental services are a huge part of safety in the hospital. So that's a wonderful thought. I appreciate that.
Yeah. And now on an unexpected stay, what should you do if all of a sudden, you're in an accident or something happens and there's an unexpected stay in the hospital? What should you do, or what should you do if you know somebody
Mhm.
who's in an unexpected stay in the hospital?
So I advocate for people to have a care partner, not a caretaker, right? Someone who needs caretaking is a different conversation, but I'm assuming we're talking about people who can talk and make decisions for themselves. I always say everyone should have a care partner, somebody who can help you get through a hospital stay, advocate for you in addition to advocating for yourself. You can bounce ideas off of, kind of keep you company. And an unexpected hospitalization, a care partner is going to be really key because, like you said, this is a surprise. Things have suddenly fallen apart and pieces need to be picked up. And it's likely not just medically, right? Unexpected hospitalizations tend to have some kind of social complication that goes along with it. Now you're missing work unexpectedly and you need to pick up FMLA paperwork, things like that. And so having somebody who can buddy with you and help you and knows you. And so the times when you're in pain and you can't say what your medication list is, they can say, like, oh, I know he's on this and he goes to this CVS, give that CVS a call. Someone who can be your partner in this. That's going to be real key for an unexpected hospitalization. If you're somebody who has like chronic or progressive illnesses and you have an unexpected hospitalization due to like a flare of this chronic or progressive illness, I always advocate that you know who is the person who's taking care of you, who is your neurologist, who is a nephrologist, and reach out to them, and or make sure the hospitalist has their contact information so that they can reach out to them. Because oftentimes there are really detailed care plans that go on outside of the hospital. And plugging these specialists in to knowing what's happening in the hospital can keep those care plans on track, right? So if you're seeing a nephrologist and now you're in the hospital and your kidney function is kind of doing worse, the nephrologist can say, like, we were preparing emotionally for dialysis. Let's start dialysis now and also do some vein mapping for a fistula. This keeps me on track with your longer care plan so that I'm contributing in a positive way instead of just kind of creating something in the hospital that's not going to fit what you need to leave. So get a care partner and reach out to the people who are taking care of you medically to let them know you're there.
Awesome. Thank you so much for that. I think that that is really good advice. I think we all think of like the mundane things, like letting someone's work know, and you know what I mean, and like that would all be roles of the care partner. And
Yeah, those things are really important. Feed the cat, right? I cannot
yeah,
tell you how many patients end up hospitalized unexpectedly, and they're struggling to find someone to get into their apartment to feed their pet, and pick kids up because you were like, I literally had someone who got hit by a car in the shopping mall, and she was like, oh my God, can someone call my kid's school to let them know that, no one's going to be able to pick them up. They need to come up with a different plan. And so having a care partner really is important.
Yeah. And that's something that you can ask, I think, a friend, or I mean, I'm lucky I have my spouse. Like he would be my person that if anything happened to me, he would know everything or almost everything, you know. But if you don't have a spouse or a life partner or a romantic partner or a parent, you can always ask a close friend or something like that
Yeah.
to just hey, if anything happens to me, can you make sure these things get done, and have that checklist for them, let them know where the spare key is, right?
Yes, yes.
So I know a lot of times people go to the hospital and they're there for, it can be any reason, and then they get discharged either home or in a long-term care facility. I just had a really big conversation about this. They go to a facility or a home, and it's a matter of, it could be hours to days before they're back in the hospital
Mm.
for whatever reason. How can that be prevented?
So those transition of care, and that there's a whole discussion about that phrase, transition of care. When I'm handing off care from the hospital to somebody else, someone else handing off care from the hospital to me, surgeons handing off care, vice versa. These transitions of care are really kind of what I would call the high danger points, right? Because this is when communication is really key. Is everybody getting the correct medication list? Is there a plan for wound care follow-up? What is the plan for the surgical follow-up? What are we doing about feeding, and when is the speech therapist coming back? When somebody goes to a next facility, those things are really important because the care team there is expected to pick up the ball and run with it. So that means that if you are a care partner, if you are a caretaker, advocating has not stopped. Now you're going to be interacting with and advocating with a different set of professionals. And so you got to keep up momentum. The things you were doing in the hospital, it has to be the same exact things that you're doing at these post-acute care facilities, making sure you're talking to the physician or the NP who's caring for a patient, asking when the next therapy session is scheduled, and touching base with the therapist about long-term feeding plans. All of those things are very, very necessary. The back and forth, what we see oftentimes is it's like a resurgence of the thing that happened that brought them to the hospital in the first place, right? So somebody who goes to the hospital for a pneumonia due to aspiration, they go to the facility and they have another aspiration event. If you find yourself in this back and forth with the same issue, this usually means a conversation needs to be had and plans need to be made about what we're accomplishing and where we are going from here. So if somebody continues to aspirate, a hospital stay is not going to change that, right? So what are we doing? What are we accomplishing? And then where are we going from here? How are we going to accomplish that thing? Because clearly the back and forth means that we are not accomplishing changing a pattern. And if you want to change the pattern, this usually means that the caretaker, the patient, the care partner, the family member, whoever it is, needs to say, hey, it's time for a family meeting. And in my book and on my website, I talk in depth about family meetings because family meetings are great tools for communication and planning, right? And so if you check out my website, drmoniquenugent.com, there's a free download on how to structure a family meeting. The who, what, when, where, why of a family meeting, right? And so if you're finding this back and forth, it usually means that goals of care have not been adequately addressed for what's happening, right? Now, there are people who are having back and forth from really active things. You have a newly diagnosed cancer, you just had surgery. Like there may be a back and forth because things are changing rapidly and we have not really figured out where it's going to even out. Diagnosis are not, fully made yet. That doesn't mean you can't have a family meeting to say like, okay, how can we mitigate this? Do we need to stay in the hospital longer until the path is back so we can really make a plan? Or, I consented to one type of surgery when we discussed a second. Does this mean that we need the other surgery that we discussed, and how can we go forward from here? Right. So that back and forth tends to be time for a discussion to make sure. And I'm not talking about just one time. There can be times where people we term fail, right? When they go home and they have another event that but then they come back and they see a specialist again and maybe get a higher dose, and then the next time they leave it doesn't happen. What I'm referring to and what you're referring to is that ping ponging that you find happens as people progress in their illness.
Yeah. And that's always frustrating for the family caregivers and things like that, because that's like you think that they're doing better, they're being discharged, and then 3 hours later mom's throwing up again, or the next day mom can't stand anymore and the facility can't handle somebody who can't stand, or
Yeah.
mom just fell again, for whatever reason. And that can be so frustrating for family members. But and obviously it's frustrating for the person going through it, going
Oh
through
yeah.
the back and forth, and it's frustrating for the long-term care staff or the home care staff or the hospital, because the hospital doesn't want to see somebody that they just sent home come back in an hour later or 6 hours later or even the next day. It's like, you got to question, like, okay, what happened between then and now, and anything could have happened, and it's
Yeah.
just
I mean, the truth is that we're all on the same team. We are all hopefully working to make sure patients are getting better. But getting better doesn't happen in a hospital. Getting better happens outside the walls of a hospital, and it's a long process. And it can also mean that, and this is something that we didn't talk about earlier, but it can also mean that living situations may need to change, right? That you mentioned mom fell again. That's a big one that I get a lot. Like, oh, you just discharged mom and she went home and she fell again. And I'm like, well, who was with her? Oh, well, she was by herself. I'm like, is that safe anymore? Because I can do as much as I can here, but if she goes home and she doesn't have the physical infrastructure and the emotional infrastructure to be successful at home, and people, you know, do need other people around. Loneliness is a thing. Just being disoriented because you're alone and someone isn't mentioning like, "Oh, mom, you took that medicine already." Those things are really necessary. And so, yeah, like I said, that ping pong, anytime I see that bing, 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 I'm like, okay, everybody get in a room and we need to have a conversation because we're not accomplishing what we're looking for. And how can we move forward?
exactly. And I think it's interesting what you said is like, people don't people aren't at the hospital to heal, or the healing happens after. And it's true, the hospital is there to get you better, like to treat the immediate
Hmm.
emergency, basically, so you don't die. um
I mean, you're not wrong. I mean, the layers of a hospitalization, you're not wrong at all. So the emergency department, you come into the emergency department, and if you won't die if you leave and you can safely be treated, it's likely they will discharge you, right? So you may show up in the emergency department and have a really bad cold or be coughing a whole bunch, and they're like, "Yeah, but you'll survive this, and you can take these antibiotics at home. You're eating and drinking, you're okay." They'll likely discharge you. Why? Because you're safe, you won't die. But if they're like, oh, this dude will definitely die if he leaves, he needs to be admitted, then you see me, and then I'll come in and say, like, oh, if I take him to the regular floor, he needs more care. He would end up and be better in the ICU. Then you go to the ICU, right? And then the same thing, you spend several days with me. And after I spent some time, I look and say, like, okay, not vomiting anymore, fever is gone, still needs several days of antibiotics, but that doesn't need to happen here. And it's likely we'll talk about discharge. There is this idea that some people have that you have to be, and people can't see this, but I'm using my air quotes, better to be discharged from the hospital. And I hear that a lot. Oh, doc, I'm not better. I'm not better. And I empathize with that. But I also really want people to understand that there are very few people who leave the hospital, quote unquote, better. Like, even people who go in to have a baby, they're still leaving in pain, bleeding, like probably have swollen feet. Yeah, they're not leaving like those Instagram ladies who went to the one of those fancy hospitals where they care for you afterwards, right? And like, that's the key is afterwards. If you're leaving the hospital, you're likely still going to be needing some care, some time. I tell people my usual equation is for every day in the hospital, expect about a week of convalescence for you to feel better, right? People kind of, oh my God, that sounds like a lot. But it's what I find to be the most conservative and the most reasonable. That if mom was in the hospital for 3, 4 days, she's not going to be 100% for about a month.
Yeah.
It's going to take her a while to start feeling well enough to start moving around and doing her thing. And so it's really about safety. If you feel like you're being discharged and you don't feel like it's safe, that's a very different conversation from being discharged and feeling like, oh, I just don't feel like I'm back to myself. You're very unlikely to feel like there's maybe if you're 22 years old and you broke a finger, and it got like a laceration at baseball practice, that'll be the person who feels quote unquote fine. But it's very rare that people are going to feel 100% when they leave the hospital, but you should feel safe. And that's the thing I want people to remember.
I like that, and thank you so much for sharing that. I think that it's always important to ask too when you're being discharged for the hospital, when your loved one's being discharged for the hospital, okay, what do I need to do at home, or what do I need to do next? And it's important also because again, if you're not following that discharge plan, you're only going to end up back in the hospital.
Hmm.
And so I think it's important to make sure that, and they give you a printout of a discharge plan, and it's not always exact, and there's always something else that you can do. So I always look over the discharge plan, and I always ask, I know I'm a pain in the butt, but I always ask questions. Okay, so it says to do this in the discharge plan. It doesn't mention what if this happens, what if that happens now,
Hmm.
but and I'm always taking notes and writing and asking, are there other questions that people should be asking when they're being discharged so they don't have to go back right away? Or
So you're being an excellent care partner and an excellent caretaker. I encourage people to have their care partner available for discharge when the discharge paperwork is given. Because there's always going to be another question asked. There's always going to be something missed if you don't have another set of eyes looking at it. Patients are often just ready to go. I want to get out of here. I want to get out of here. And they're not looking at the medication list to make sure every single thing is correct and that all the listed phone numbers for the follow-up appointments are there, right? I think you're right spot on. The number one thing that I advocate for people is to do their own medication reconciliation. So what is that? The medication reconciliation is a process where we look at the medicines that you're taking and the medicines that we want you to take, and we see where it's safe for these lists to combine, which medicines you should continue taking, you should stop taking while you're taking new medicines, and then restart taking it, and etc. The medication reconciliation process is done when you're admitted to the hospital. That's done during specific transitions of care, like when you come out of the ICU or surgery, but it's done on discharge, right? On discharge, the physician is going to say, what are all the medicines they're taking in the hospital? What are the ones they're taking at home? And which ones do I want them to now take at home that are new, to stop taking that they were taking at home before, or which ones that they should stop altogether in the hospital or restart after they're done with something new, right? That discharge medication reconciliation is key for safety for discharge planning. I want you to take that discharge medication reconciliation form that you're given on your discharge paperwork, and when you go home, do that again. Look at the list of medicines and look at your physical pills and your insulins and say, what is on this list that I should be taking that's not here? Okay, I got to go pick up this antibiotic. What is on this list of medicines that I shouldn't be taking that I still have a huge jar of? Right? So like, oh, I'm no longer taking this blood pressure medicine. It's not safe for me. I'm going to make sure that I take it away and dispose of it because the last thing you want is to take a medicine that you shouldn't be taking that complicates your care or has a nasty interaction or side effect with some new medicine. And then so like, oh, which medicine should I retake in 3 days? Oh, they said I should start taking back this heart medicine in 3 days, right? And so that medication reconciliation process, I want you to do it when you go home again. Do it for yourself and make sure that you have the correct things that you need. The other thing I want people to do on discharge is realize that there's two other prescriptions that are given. There is a diet prescription, and in my book, I call them prescribed diets because oftentimes if we're saying that you need a specialized diet, it's for a reason. If we are prescribing a diabetic diet, if we are prescribing a cardiac diet, these things can have really significant effects on how much medication you may need, right? How much insulin you may need. If you're eating more carbohydrates than you were when you were in the hospital, then your sugars are not going to be what we saw in the hospital, right? And it's the same thing if you're going home and eating a whole lot of chips and drinking a bunch of water, the diuretic pills that I prescribed for you or may not have the same type of effect because they're not keeping up with your diet. So can look at the prescribed diet and see why this diet was prescribed, and then try your best, but give yourself space and grace to learn how to live with these prescribed diets. It is very difficult. Food is emotional, it's cultural, it's celebratory, it's everything. It's fun. For some people, it's also a living, right? So make sure that you give yourself space and grace to learn and try to figure out how to help make these diets work for you, your life, your cultural, religious experiences and expectations. Really try and stick with them because it can have other side effects. For people who have had strokes or other neurologic conditions, they may leave with different textures of diets. We may say, oh, this person needs a soft diet. This person needs a chopped diet. If someone leaves with a tube feed diet, these prescribed diets can be very important for safety. We don't want people choking, aspirating, and have a bad outcome. But they also can change. It can be that you see a speech therapist and things change over time. So I want people to look at that and realize that the diet is a prescription. The other thing that is prescribed that people don't think of a prescription is assistive devices. If you leave with a walker, whatever it takes to use that walker, if you have to bedazzle it, put tennis balls on the bottom, paint it hot pink, whatever it is that it takes for you to be comfortable using that walker on a regular basis, please use the walker. Use the cane. Use whatever assistive devices that you have been, as a lot of the times they are for your safety. They may not be permanent, and they can help you avoid another hospitalization,
Yes.
right? I meet a ton of elderly patients who do what I call furniture walking, where they just go from the table, they hold on from the table to the side table, from the side table to the chair. If you were prescribed a cane for the home, use your cane in the home because just like a prescription for an antibiotic will prevent an infection, a prescription for a shower chair will prevent a fall in the shower. So whatever assistive devices you were prescribed, please treat them like a prescription and use them as directed.
Yes, thank you for the as directed part. I just had a conversation yesterday with somebody. We talked about walkers being used improperly or not getting enough training on how to use the walker.
Mhm.
Being told, "Oh yeah, you need a walker," and then pushing it along while you're shuffling behind it, and how that can cause falls.
I've seen a lot of very creative ways that walkers are used. I've seen in the supermarket, I often see grocery carts being used as walkers, right? Those scare me as well because they can just roll away from
Oh
somebody,
yeah.
you know. But I do try and frame them as prescriptions, and as prescriptions can change over time. If you stick with it, you may be able to go to physical therapy and you may not need it again. But if it's a permanent thing, if you need a walker permanently, avoiding a fall will help keep you independent. And that's really what people are looking for is
Yep.
independence, autonomy, being able to live their life as they see fit.
Absolutely 100%. Thank you so much for that. And I guess I kind of have my final two questions now. We're kind of wrapping up. My second to last question, my favorite question to always ask my
Yeah,
guests. What is your favorite form of self-care?
I love this question because I am reflecting on that myself right now. I am I am making some personal transitions and professional transitions that are forcing me to reflect on how I can stay viable in all the things that I do for the long term. I'm a mother, a physician, a daughter, a wife, a daughter-in-law. Like all of these things require a lot of different attention and different hats. And so I have started re redoing gratitude journals. And it's something that I'm starting also with my girls on their way to school and from school. I'm starting to say to them, tell me what's going to be your favorite thing today. And then at the end of the day, what's the thing you are grateful for that happened today? Because what I at least find for me personally is that there's so many different ways that somebody is pulled and so many different roles that I have to fulfill that I easily can feel frustrated, upset, and less than. And I have found that the practice of gratitude, I just finished this book, The Happiness Advantage. The practice of gratitude and putting my mind in a space to regularly be able to see the positive helps me with my endurance to keep going. That if I just see that that day is going to be horrible, then like my energy, my output, my vibe, my everything already is bad for the day, and slogging through that day is that much worse. But if I can train my mind to see the positive thing, then that gives me the energy physically, emotionally, and spiritually to keep doing the things that I'm doing. And so as I try and grow in this work as an author, I'm a physician. This isn't really something natural to me to like talk about myself and things like that. I can easily get discouraged and be like, oh, no one's listening. But people are listening and people want to hear it. And I have something to share. And if I keep seeing the positive, I'll keep going and people will keep getting my message. So my gratitude journal is something that I've picked up again and I've started doing it with my girls.
That's awesome. I love that. And I love any kind of self-care that you can incorporate with other people, especially for family caregivers. Caregiving can be isolating. It can
Very.
be very isolating. And if you can find a way to have a form of self-care that's simple, that you can that you can do with either the person you care for or someone else or a friend, that just helps the isolation go down. It's just one less thing you feel less isolated in. Um, and again, isolation can lead to burnout, and it can
Burnout,
just make it worse.
depression, all like worsening health outcomes for yourself as a caretaker, right? So yes, you're right.
A,
Don't isolate yourself.
a,
Find the
a
community.
1000%. And in self-care can look different for everybody. And if social self-care for you is a cup of tea with a friend or a glass of wine with a friend, that's fine too. That's fine too. But I love it. I love that you're doing the gratitude with your daughters instead of just like the venting, like, I had the worst day ever.
Yeah.
Um, I really love that. Like, okay, today I'm grateful for this.
Yeah.
Um, I love that advice. And I might actually, with my little circle of friends who kind of support each other, I might just do like a quick little um, hey guys, what are we grateful for today? Just as a reminder. I love it. And now my final question for you. Where can my audience find you and your book for more information?
Thank you so much for having me, and thank you for your audience for opening their homes to let me speak to them for a little bit. So you can find my book anywhere where you buy books online, Amazon, barnesandnobles.com, those places. You can also find me on my website. I mentioned it earlier, drmoniquenugent.com. That's DrMoniqueNugent.com. And that website is where you can go and get some free downloads. And I want everyone to go. We talked about the download that I have around caring for planning family meetings. I also have one to practice filling in your medical history. Getting that free download will add you to my newsletter list. And I am launching my blog this month. So the people who are on the newsletter list already are just, got this month's put out, I should say, posting that I did. And I'm meeting with my website people tomorrow to continue to grow and make my website more of an interactive resource for people where they can get things like these free downloads, access to other forums, and my, different podcasts that I've been on, get the blog. I'm really going to be focusing on that this year. If you are a social media person, you can find me on Instagram, which is I am at the happiest hospitalist is me. And I am not the greatest at Instagram yet. So you can join early and watch my evolution as I learn to be more in this space. But it's also a big goal of mine this year to can make this a resource again for people and a community and really grow that as well. So I'm doing a few more postings and like you can chuckle along at my like awkwardness, but also I hope you get something good out of it. So check me out online at drmoniquenugent.com, my Instagram, which is the happiest hospitalist, and also Amazon, barnesandnobles.com, anywhere where you buy books.
Awesome. Thank you so much, Dr. Monique Nugent. I appreciated having you here, and I felt like this was a great conversation and very informative for and relatable because how many of us have been there where we're taking care of somebody and they're in and out of the hospital, or everybody's gonna have to be in the hospital someday. It's
The
just
DM, like I said, the
exactly.
DMV and the hospital is the two places that most Americans will find themselves at some point in time.
Exactly. So thank you so much for your information and your tips and your advice. I am truly grateful for that. And that will wrap up this week's episode of Caregiver Chronicles. If you like what Dr. Nugent said in the show or you found it beneficial, you know somebody who could benefit from this information, please share this episode with them. All of her links will be in our show notes in the description. We also ask that if you like what we had to say and you want to support us, you can do so through our website, stelmachbrownmedia.com, or through Buy Me a Coffee. We have a Caregiver Chronicles tab on there. If you can't support us monetarily, we completely understand. And the best way to really help us out is to like our show, share it with a friend, share it with all your friends, and subscribe to us and follow us on social media. Thank you so much, and we'll see you next week.